Hello, in this presentation we shall discuss the assessment and treatment planning of impacted wisdom teeth, starting with clinical assessment, followed by assessment on radiographs and cone beam CT. Impacted wisdom teeth may have a wide range of clinical presentations. Therefore, it's important to evaluate each case objectively. Impacted wisdom teeth may be asymptomatic and pathology free on one hand, and on the other hand, they could present with acute pain, suppuration, signs of spreading infection, advanced tooth decay, periradicular pathology, root resorption of the adjacent teeth, and association with pathological lesions such as a dentigerous cyst. Similarly, it's important to evaluate if they are leading to difficulty in maintenance of oral hygiene due to presence of stagnation areas distal to the second molars, and thereby increasing the risk of distal caries on the adjacent second molar or increasing the risk of periodontal pocketing. So these factors need to be evaluated uh, before making a decision whether an impacted wisdom tooth warrants removal or it can be left under observation. Clinical assessment of impacted wisdom teeth follows standard procedures starting with medical history, dental history, and clinical oral examination. It's very important to look at the patient factors such as age, because generally speaking, wisdom tooth removal is not recommended in children or adolescents, and similarly, wisdom tooth removal in elderly patients increases the risk of complications such as delayed healing or other complications related to comorbidities such as diabetes mellitus, immunosuppression, etc. For example, wisdom tooth removal may be generally more challenging in a bulky adult male compared to a thin female. So all these factors need to be considered when planning your treatment for impacted wisdom teeth. It's very important to look at the eruption status of the tooth. If the impacted tooth is partially erupted, it is more likely to be associated with pericoronitis or dental caries, whereas deeply impacted wisdom teeth, which are unerupted, are very unlikely to be responsible for any symptoms. It's also very important to look at the relationship of the impacted tooth to the adjacent teeth. Uh, if the adjacent tooth is rotated, if the adjacent second molar uh, is at increased risk of caries due to stagnation areas on the distal aspect of the lower 7, and finally evaluate the patient's mouth opening and access, because uh, adequate mouth opening and access to the operative site is essential if you are planning to remove the wisdom tooth in the immediate future. Patients who have acute infection with trismus may not be the best candidates for wisdom tooth removal immediately, and the infection may need to be controlled before any operative intervention. During the radiographic assessment of the wisdom teeth, some of the important things you should note are the angulation of the wisdom tooth, the depth of impaction, morphology of the third molar crown and roots, relationship to the second molar, relationship to the mandibular ramus for mandibular wisdom teeth. Very important, the relationship of the impacted wisdom tooth to the inferior alveolar nerve canal, and finally the presence of any associated pathology such as a dentigerous cyst. Generally speaking, orthopentomograms are standard imaging tools for assessment of wisdom teeth, because on a periapical radiograph, you may not always be able to see the periradicular area of the uh, third molar, the relationship of the third molar root apices to the inferior alveolar canal, and the relationship of the impacted third molar to the mandibular ramus, or the actual depth of impaction of the wisdom tooth in the mandible. So therefore, for mandibular wisdom teeth, an OPG is recommended as an initial screening tool, and it would allow you to assess the angulation of the tooth, the depth of impaction, the relationship of the third molar with the adjacent second molar, the relationship of the third molar with the inferior alveolar nerve canal, etc. For maxillary third molars, sometimes you can get away with a periapical as long as you can capture the root apices of the third molar and their relationship to the maxillary antrum. During the radiographic assessment, the first step is to carefully assess the angulation of the wisdom tooth, whether it's vertical, distoangular, mesioangular, or horizontal. Generally speaking, distoangular wisdom teeth are most difficult to remove, and sometimes one may be deceived by their visual impression. For example, on this image, the wisdom tooth appears to be more or less vertical. But if you were to draw perpendicular through the furcation areas of the 7 and the 8, you would see that the two lines drawn through the furcation are divergent, which means that the impacted wisdom tooth is distoangular. Without this objective assessment, one may be deceived in believing that the wisdom tooth is actually vertical, whereas in reality it has a distoangular position. The other way to assess whether a tooth is distoangular, vertical, or mesioangular is to assess the width of the interdental septum between the 6 and the 7 and compare it to the width of the interdental septum between the 7 and the 8. If the tooth is vertical, this width would be equal to the width of the interdental septum distal to the 7. In case of distoangular teeth, the width of the interdental septum distal to the 7 is less compared to the width on the mesial aspect of the 7. Similarly, with mesioangular impacted wisdom teeth, the width of the interdental septum distal to the 7 would be greater compared to the width of the interdental septum mesial to the 7. Similarly, for horizontally impacted wisdom teeth, if you were to draw an imaginary perpendicular through the furcation of the roots of the 7 and the 8, they would meet at right angles, which is indicative of a horizontal position of the impacted wisdom tooth. Next, you need to assess the depth of the impacted wisdom tooth in the bone and its relationship to the adjacent second molar. So think of an imaginary point of application close to the CEJ on the impacted wisdom tooth and relate it to the adjacent second molar roots. If the point of application is at the level of the coronal third of the roots of the second molar, then generally that is considered to be a relatively easier surgical extraction. If the point of application is adjacent to the middle third of the roots of the second molar, then it's a moderately difficult impacted wisdom tooth to remove. And finally, if the point of application on the third molar is related to the apical third of the roots of the second molar, then it is a difficult and challenging wisdom tooth removal. A very important and vital part of radiographic assessment of the wisdom tooth is to assess the relationship of the root apices of the third molar to the inferior alveolar nerve canal. Obviously, the inferior alveolar nerve is a soft tissue structure and you cannot see the nerve on radiographs, but what you can see is the position of the inferior alveolar nerve canal. You can, on this sectional OPG, you can clearly see the position of the mandibular foramen, and the tram lines indicate the configuration of the inferior alveolar nerve canal. Now, the relationship between the root apices of the third molar and the inferior alveolar nerve canal is highly variable, and it's very important to assess this relationship objectively to quantify the risk. So if the root apices of the third molar are clearly demarcated from the inferior alveolar nerve canal shadow and there is clear bony separation, then it is a low risk case. On the other hand, if the root apices are impinging on the inferior alveolar nerve canal, then it's a moderate risk to the inferior alveolar nerve during surgical removal of the wisdom tooth. And finally, the root apices may begin to overlap the inferior alveolar nerve canal shadow, and that indicates a high risk of iatrogenic damage during surgical removal of the wisdom tooth. And it is generally these categories of wisdom teeth which warrant a cone beam CT for treatment planning, whether you are going to carry out a conventional surgical extraction or whether you may need to do a coronectomy. Finally, the highest risk of inferior alveolar nerve damage is associated with impacted wisdom teeth where the root apices completely overlap the inferior alveolar nerve canal shadow. As you can see in this image, you can see bilateral horizontal impactions of the mandibular third molars, and on both sides the root apices seem to completely overlap the inferior alveolar nerve canal shadow, and this is indicative of the highest risk of nerve damage during surgical removal of these teeth. This lower right impacted mandibular third molar shows a very high risk category wisdom tooth. As you can see, the mesial root is completely overlapping the inferior alveolar canal shadow, and not only that, there is a marked dilaceration on the distal root, and thirdly you can see a large juxtaapical radiolucency which might indicate a defect in the roof of the inferior alveolar nerve canal, and this might mean that the nerve is in direct communication with the distal root. So this is an example of a very high risk mandibular third molar, and it might warrant an OPG before you carry out any operative intervention. Other observations which might indicate a very high risk of nerve damage during surgical removal of the wisdom teeth include discontinuity in the shadow of the inferior alveolar nerve canal, sudden deviation of the inferior alveolar nerve canal, darkening of the roots of the third molars adjacent to the inferior alveolar nerve canal, and finally any marked dilaceration on the roots of the impacted third molar. All these observations would be indicative of a high risk of nerve damage. Finally, you need to look for any associated pathology in relation to the impacted third molar, and on this occasion you can see a large pericoronal radiolucency associated with the lower right mandibular third molar. This is most likely to be a dentigerous cyst, and it might be best to plan enucleation of the cyst along with the removal of the mandibular third molar. And you can also see that due to the presence of the cystic lesion, the mandibular third molar is displaced close to the lower border of the mandible, and there may be a risk of fracture of the mandible during removal of the third molar. So you might want to marsupialize this cystic lesion to allow some bone healing, followed by removal of the mandibular third molar and enucleation of the cyst as a secondary procedure. If you encounter wisdom teeth which show a close relationship of the root apices of the third molar with the inferior alveolar nerve canal as observed on the OPG, such as overlap of the inferior alveolar canal shadow by the root apices, sudden deviation of the canal, darkening of the roots, or dilaceration of the roots of the third molar, then that might be an indication to carry out a cone beam CT scan prior to finalizing your treatment plan. So the panoramic view is the most common one which is used for assessment of impacted wisdom teeth using cone beam CT, and cross-sectional views will show you the exact relationship of the inferior alveolar nerve canal with the root apices of the mandibular third molar. So on this cross section you can see that the root apex of the third molar and the inferior alveolar nerve, you can see the relationship, and on this occasion it is clear that the inferior alveolar nerve is lingual to the root apex of the mandibular third molar, and also it is inferior to the root apex. Similarly, you can also see the precise position of the inferior alveolar nerve canal if there is darkening of the roots and the shadow of the inferior alveolar nerve canal is not clearly visible on an OPG, then you can see the relationship more clearly on a cone beam CT scan. Now just a couple of words on the value of cone beam CT. Obviously it sounds posh and commercially it might be a selling point for many practices if they offer a cone beam CT. But a recent systematic review shows that in most cases when cone beam CT scans are taken, it does not seem to influence the treatment plan for the impacted third molar. So cone beam CT is only recommended if there are objective signs of a high risk of nerve damage on an OPG and an operative intervention is planned. If, for example, you observe deeply impacted wisdom teeth which are asymptomatic and pathology free in an 18-year-old and no intervention is planned, then there is no point in taking a cone beam CT. Like any investigation, a cone beam CT for impacted wisdom teeth, you should have a clear indication to perform this investigation, because not only there is a higher cost for the patient, but also there is a much higher radiation dose. So if a cone beam CT is unlikely to influence your treatment plan, you might need to think if you actually need one. Finally, towards the end of the presentation, we can see the limitations of OPGs because they provide a 2D view of a 3D object such as a tooth. So this patient presented with bilateral partially erupted maxillary third molars which showed signs of pericoronitis bilaterally, and looking at on the OPG, the root apices of both the maxillary third molars seemed fairly straightforward, conical, and no accessory roots were identified on either side. You cannot note any signs of dilaceration, etc. But when these teeth were actually removed, you can see that the right maxillary third molar has a marked dilaceration on one of the roots, and it was actually a 4-rooted molar. And similarly, on the left side, the third molar had a marked dilaceration. So therefore, it is important that whilst you can rely on your radiographic assessment using an OPG, you must be always mindful about what the tooth wants to do, when you actually extract it. And if you encounter any undue resistance or the tooth is particularly stubborn, then you might want to reevaluate the radiograph and consider additional investigations such as a cone beam CT. In summary, there is a wide variation in the difficulty level of impacted wisdom teeth with regards to surgical extraction, and it is very important to assess each case individually using a thorough clinical assessment and a radiographic assessment. And if the radiographic assessment warrants, a cone beam CT scan may also be undertaken. Traditionally, the clinicians in the UK have followed the NICE guidelines, which came back in the year 2008. The NICE guidelines on wisdom teeth advised against extractions of pathology-free asymptomatic teeth, and the key advice was that only symptomatic wisdom teeth or those wisdom teeth which were associated with a pathology need to be removed. However, there are situations where the impacted wisdom tooth may itself be asymptomatic and disease-free, but it may pose risk to the adjacent second molars. For example, due to food stagnation, there may be a high risk of distal caries on the lower 7 or development of periodontal pockets. So these observations have led to publication of this guidance by the Royal College of Surgeons of England, parameters of care for patients undergoing mandibular third molar surgery, which came out recently, and they highlight the need for shared decision making between the clinician and the patient for a more individualized, patient-centered approach rather than applying the NICE guidelines blindly. In terms of the management, the main options for impacted wisdom teeth range from conservative management for pathology-free asymptomatic teeth. These can be kept under observation, whereas if the impacted wisdom tooth is causing symptoms or is associated with a pathology, they can be extracted. Finally, if the extraction is likely to be associated with a high risk of nerve damage, then the clinician may also consider doing a coronectomy rather than an extraction. Operculectomy was also considered to be one of the options, but usually the gingival tissue regrows and there is recurrence of symptoms such as pericoronitis. So therefore, operculectomy is no longer considered a standard treatment approach for impacted wisdom teeth.